In the oral bladder session, there was data presented using Erdafitinib, both for patients with metastatic disease, where the results show a similar sort of long-term survival to patients with pembrolizumab as monotherapy. This is a direct head-to-head comparison, with Erdafitinib maybe doing a bit better in the first few months and then pembrolizumab later, but wasn't superior to pembrolizumab, which was what the study was designed to show. So it showed similar results, but actually probably not successfully so, and probably not sufficient to displace immunotherapy as a second-line treatment. Elsewhere in the meeting later today, we're expected to see the presidential session where results of upfront pembrolizumab and enfortumab vedotin has been presented, which the pre-released abstract suggests shows a significant survival advantage for those treatments. So it may well be that there's then a role for Erdafitinib as a second-line treatment following those treatments. And the previous part of the trial that was published earlier this year did show that Erdafitinib was better than second-line chemotherapy following first-line chemotherapy and immunotherapy. So I think a useful treatment there, though it's quite clear also there are significant toxicities, particularly skin and eye and oral toxicity, so it's not necessarily an easy drug. There was also data on the use of Erdafitinib in patients with non-muscle invasive bladder cancer. The trial wasn't very successful because it was underpowered and didn't complete recruitment, but it did actually show significant control rates from using Erdafitinib. But again, the conclusion from the author and the discussant was very much that useful activity, but probably too toxic for a very good prognosis group of patients. And I think that's been then taken forward into more local application of the drug, which may be more reasonable.